Give them a minute. So I think we will begin this webinar. Good morning, good afternoon. And for those who may be joining from the Eastern United States, good middle of the night. My name is Sheena Curry and I work with JPIGO as a Senior Technical Advisor and in this role with the IWAG Steering Committee. Co-moderating with me today, I'm happy to introduce my colleague, Stacey Stender, also a Senior Technical Advisor, and Blami Dow, Regional Technical Director in West Africa. JPIGO is an international NGO affiliated with Johns Hopkins University, dedicated to improving the health of women and families. So a warm welcome to you all on the first virtual webinar to be held as part of the Streaming IWAG 2020 webinar series. This webinar features panels that were planned for the IWAG meeting originally scheduled for Bangkok and cancelled due to the COVID-19 pandemic. This year's theme, Bridging the Divide, Operationalising Sexual and Reproductive Health and Rights in the Nexus, asked presenters to share findings and lessons learned from working on sexual and reproductive health rights at the intersections of the humanitarian, development and peace sectors. With so many webinars, you may be familiar with the format of a Zoom call. During this webinar, which will last approximately 1 hour, if you have any questions for the panelists, please use the question and answer feature and we will do our best to respond to these. The chat option, also at the bottom of your screen, is an opportunity to respond to questions from the presenters. Please be respectful and constructive when using the chat feature. We will first hear from the three presenters, then take questions after. So this morning and this afternoon, I have great pleasure in welcoming three panelists from diverse settings and backgrounds who will share with us their experiences of investing in the health workforce to strengthen SRH health services in fragile settings. We are all aware that improving health service coverage and health outcomes is dependent on the availability, accessibility, acceptability, and quality of human resources. A building block for healthcare everywhere, the health workforce in fragile and humanitarian contexts face additional challenges and needs. Our first speaker this morning, and I am very happy to welcome, is Erickson Bernardo, a registered nurse by profession, President of the Philippine Society of SRH Nurses. Erickson chose not to confine himself within the conventional four corners of a hospital and took on the road less travelled in joining the development sector. He is a staunch advocate of sexual and reproductive health and specialised both in didactic methods and professional practice since 2012, and finished his Master of Arts in Nursing with a thesis on reproductive health in emergencies. An avid fan of Harry Potter, he collects almost anything Potter related and also has a wanderlust, keeping a memento of cultural crafts to remind him of places he's been to. Our second speaker today is Pamela De Camilio, a GBV specialist with UNFPA in Jordan. Pamela holds a master's degree in development studies and has 12 years of experience as a GBV specialist in programming to promote the rights and needs of women and girls in humanitarian and development settings in different complex contexts of Asia, Africa, and the Middle East. She covers the position of GBV subcluster interagency coordinator in different settings for international NGOs and UN agencies. Pamela is a feminist, a runner, passionate about her job, and she speaks 4 languages, including intermediate level of Arabic. And thirdly, our third speaker is Zara Mirzai, a midwife with 14 years experience working in Afghanistan. Zara is currently the midwifery and nursing team leader for Japago in Kabul, Afghanistan, and in her voluntary role, the president of the Afghan Midwives Association. She's an executive board member of the Nurses and Midwives Council and the White Ribbon Alliance Afghanistan, and in these roles works closely with the Ministry of Health in developing policies, training manuals and guidelines, and strengthening midwifery activities. So we will begin this morning. So just bear with me. Sorry, I just couldn't move the slides. Let me try again. Okay, my screen is... Apologies, everyone. Let me pull up this one to see if I can move the... Okay, so we will begin this morning with a presentation from Ericsson on the Agreement, Awareness and Readiness and Health System framework and the Minimum Intervention Service Package for Sexual and Reproductive Health in Emergencies and Disasters among Health Workers. Ericsson, over to you. Thank you.
Thank you, Sheena. Good morning, good afternoon, good evening. I'm Ericsson Bernardo from the Philippines, and I'll be presenting an Agreement, Awareness and Readiness and Health Systems Framework and the Minimum Initial Service Package for Sexual and Reproductive Health in Emergencies and Disasters among Health Workers. Next slide, please. Next slide, please. As a backgrounder, the Philippines lies in the Pacific Ring of Fire and ranks third to Vanuatu and Tonga as the most disaster-prone country in the world, according to the 2016 World Risk Report. Further, in November 2013, when Super Typhoon Haiyan devastated central Philippines, over 16 million people were affected and more than 4.1 million people were displaced. UNFPA Philippines has noted that there were 3.75 million women and girls of reproductive age who were affected by the disaster. This includes more than 270,000 pregnant women and 180,000 lactating mothers who were denied of their indispensable need for antenatal care. Adolescent boys and girls were not provided with correct information on how to prevent teenage pregnancies. And violence against women and girls were noted to increase by more than 75,000 from 375,000. As a response, in Feb 2016, the Philippine Department of Health issued Administrative Order 2016-0005, adopting a national policy on the Minimum Initial Service Package for Sexual and Reproductive Health in Health Emergencies and Disasters. Next slide, please. Next slide, there you go. For the methodology, this study, go back to the previous slide, please. Can I have the previous slide? This study was conducted in a first-class local government unit in Metro Manila, Philippines, with a total land area of 15.71 square kilometers, representative of 2.54% of the entire National Capital Region. This is composed of 21 local units and a total of 22 health facilities providing services in the development setting. 56 respondents out of a total of 63 health workers, including doctors, nurses, and midwives, participated in the study, with at least one respondent from each local health center thus representative of the entire local government unit's health facilities. The respondents were asked to complete a structured questionnaire divided into 3 parts. First, their profile comprising of age, gender, educational attainment, type of service provided, length of service, and relevant trainings attended. Second, indicators with regard to the World Health Organization's health systems framework. And last, indicators from the monitoring and evaluation checklist for the MISP. Analysis of data include frequency and percentage, weighted mean and standard deviation, analysis of variance, t-test, and Pearson R correlation. Next slide, please. The study is anchored in a modified version of trans-theoretical models behavior change continuum as applied in reproductive health, particularly to the use of postpartum family planning by Cooper et al. In 2013. TTM, which was originally posited by James Prochaska and Carlo Di Clementi in 1983, provides a basis for evaluating a person's readiness to perform an unaccustomed skill, and given that MISP is a newly adopted Philippine national government initiative, the framework was used to guide and assist in looking at the awareness of the respondents at the local level. Next slide, please. Key findings in terms of profiles. Majority of the respondents were females, aged 45 to 54 years old, college graduates, and had been providing services for more than 11 years. With regard to type of service provided, all the respondents were providing all SRH services, including safe motherhood, family planning, STI, HIV and AIDS, and gender-based violence. With regard to capacity building, mostly include family planning and neonatal health-related trainings, such as family planning competency-based training level 1, lactation management training, and essential intrapartum newborn care. However, the respondents lacked training on disaster and emergency management, with only approximately 1 to 5% with trainings on community-based disaster risk reduction and management, pre-disaster risk assessment, rapid damage needs assessment, and health incident command system. And lastly, there were also a very minimal number of respondents with training on the MISP for SRH. Next slide. In terms, there was an overall level of agreement to the World Health Organization's health systems framework at 3.20 overall weighted mean. And in terms of the respondents' awareness and readiness, there was an overall moderate level of awareness and readiness with overall weighted means of 2.94 and 2.68 respectively. However, significant disparities were noted in terms of the respondents' awareness as compared to their readiness across all indicators. Worth mentioning is in terms of prevention of excess maternal and neonatal mortality and morbidity, wherein there is moderate awareness with only slight readiness at 2.76 and 2.45 weighted means respectively. Next slide. Only age was found to be significantly different in terms of pharmaceuticals and health technologies at p-value 0.011 when agreement to the World Health Organization's health systems framework and profiles were considered. Next slide. Neither of the profiles were significantly different when it comes to all indicators relative to awareness and MISP for SRH. However, age, in contrast to reduction in the transmission of HIV and relevant trainings attended as compared to coordination of the MISP, were both found to be significantly different at 0.05 level of significance with p-values of 0.20 and 0.019. Next slide. In addition, among the building blocks, the agreement on health information systems, pharmaceuticals and health technologies, and leadership and health and governance presented a low significant relationship in terms of the awareness predominantly on reduction in the transmission of HIV, with computed p-values of 0.049, 0.019, and 0.014 respectively at less than 0.05 level of significance, and priority activities in addition to the MISP with computed p-values of 0.029, 0.013, and 0.012 respectively at less than 0.05 level of significance. Next slide. Further recommendations. First, the government should continue to mainstream the importance of MISP. The local government units should ensure that the whole gamut of services, including MISP, as enshrined in Republic Act 10354, or the Responsible Parenthood and Reproductive Health Act of 2012, will be fully implemented by making resources, especially financial, human, and logistical resource available within the locality. Likewise, the local government unit should see to it that provision of reproductive health services in times of emergencies and disasters is incorporated in their local risk reduction management plans. Second, there is a need to heighten awareness on MISP among stakeholders. This includes awareness raising and advocacy activities, such as the conduct of multi-stakeholder dissemination forums and community dialogues, as well as production of information, education, and communication materials in the vernacular and major dialects. Third, frontline health workers need to be capacitated not only on SRH, but also on disaster and emergency management to ensure that they are ready to continuously provide vital reproductive health services even in times of disasters and emergencies. Rollout of trainings must be made part of the preparedness phase of disaster management. Fourth, the community should continue to demand for their right to SRH services regardless of setting, whether in times of development or during times of humanitarian crisis, and just now, the global pandemic of COVID-19. Lastly, there should be future researches made on the subject matter of reproductive health in emergencies so as to broaden the knowledge in the field. Next slide. And that concludes my presentation from the Philippines. Maraming salamat po.
Thank you so much, Erickson, for the excellent presentation. And I think it would be a very interesting, if this study was conducted in other similar settings, what the findings would be. So thank you once again. We will now move on to the second presentation, and I'm welcoming Pamela to discuss with us building the Jordan government's health response to GBV, a demand-driven journey from emergency response to integration into national systems. Thank you, Pamela.
Thank you, Sheena. And good morning and good afternoon. This is Pamela. I'm speaking with you from Amman. I want to thank IWAG for having me and also GPGO colleagues for organizing this session. So today I will bring you into a journey of building the national response to sexual violence in Jordan. This was a long journey that took us almost a decade and took my UNFPA colleagues a lot of efforts, but also efforts from our partners, allies in the civil society, in the government, and other UN agencies. In every context I worked as a GBV specialist, talking about sexual violence is always labeled as a sensitive issue, and the culture of silence and blame and shame, it's used as an excuse not to talk about it, or not to tackle the issue. So it took an entire village in Jordan and almost 10 years to attain the change we wanted, but we want to share the experience with you that this change is possible. Next, please. Next slide. So Jordan's response to the Syria crisis has been moving through different stages of a humanitarian response over 9 years of conflict, moving from an acute phase to a more protracted response. This presentation will outline how UNFPA Jordan, together with partners, has promoted the sustainability of the intervention, showing how the initial emergency intervention opened up for the development of policies and strengthened the national system, contributing to the resilience of the survivor, of the community and all the country for both refugees and host communities. Next, please. So I have a small interactive exercise. I want to bring you, all of you in Jordan with me. So I'm gonna read a question and ask you to basically guess the reply and write it on the chat box. So since the start of the conflict in Syria in 2011, Jordan has shouldered the impact of a massive influx of Syrian refugees. So which one you think is the percentage of Syrian refugee over the Jordan total population? Is it 5%, 10%, or 20%? Can you guess in the chat? Can you write down? Okay, a couple of colleagues are saying 20%, a couple are saying 10%, and 10% is the correct answer. So 10% is the percentage of Syrian refugees on the total population. Also consider that Jordan is a middle-income country, also hosting high percentage of Palestinian, Iraqi, Somali, Sudanese, and Yemeni. So if we add also those nationalities, the percentage goes upper than 10%. Next question. So in Jordan, we have three main refugee camps. One is called Zaatari camp, that is a town, as one of the larger refugee camps in the world. Then we have Azra camp and the Emirati camp. But of the 670,000 Syrian registered in Jordan, the majority actually lives in town and not in camps. Can you guess the percentage of Syrian refugees living in urban areas? Is it 51%, 61%, or 81%? We have 51, 61, 81. We have all the percentage, 51, 61. The correct one actually is the highest. 81% of Syrian refugees live in urban areas, not in camps. So this is very important for us also to understand that this means that they must find a way to pay for things like rent and transportation because they live in the main urban areas. So next, our final question for the facts about Jordan. So Syrian refugees arrive in Jordan and arrive in a country where unfortunately violence against women is a commonplace, but also in the Syrian community, this happens very often. So according to the Demographic Health Survey result of 2018, actually we see that there is a lot of tolerance on violence against women and tolerance on wife beating. Can you guess the percentage of Syrian women that agree with at least one reason for wife beating? Is 41%, 61, or 91? So we have few 41, 61. Yes, the correct is 61. So more than half of the Syrian women think that in certain circumstances, it's okay, it's justified that the husband is beating the wife. And when in the DHS, when they were listing the circumstances, there were things like burning the food, being late on coming back home, children not performing well at school. Those were the reasons why it was justified for them to be beaten. And I also want to mention that also the legal framework in Jordan, it has been improving and protecting women more and more, but also there are still provisions that are actually not protective of women's rights. For example, marital rape is not considered a form of violence. Next, please. So those are the risks, and this is the context where we are working. In the wake of the Syrian crisis, hundreds of refugees arrived in Jordan, and as a part of delivering the MISP, the Minimum Essential Service Package, UNFPA and partners procured the clinical management of rape kit and start providing training. So the clinical management of rape services was firstly established in the camp, in Zaatari camp, in the biggest camp in 2012, and then in Azra camp. And then in those first year of the crisis, annual trainings on CMR were conducted both in the camp and outside the camp, and UNFPA continued to invest in capacity building and in the provision of commodities. It was relatively easy to establish the service in the camp, but for the government, was not possible to have it outside the camp unless it was within government policies and protocol. So we were in 2012, 2014, we were in a moment where actually the provision of medical care to survivors of sexual violence in refugee camp was better, with a clearer referral pathway, created discrepancy between the services created in the camps and what was offered in urban areas. So the work of the national partners in the camp serve also as a model to show that when services are available and they abide to confidentiality standards, survivors start to come forward and seek help. Because also one of the reply we were getting was, we don't have many survivors of rape. They don't come to our facility. This is not a priority. But this is not a priority because the services are not there. So why survivors should come to the health facility and seek help if the service is not there? But in the camps, as we set up the service, survivors were coming forward and seeking help. So this was a very strong advocacy point. So our first, next slide, please. Our first big milestone was actually the development of the clinical management of rape protocol. UN agencies together, UNHCR, UNICEF, and UNFPA. You can see on the left, this is actually the cover of the clinical management of rape protocol. So the three agencies work together with Ministry of Health and NCFA, the National Council for Family Affairs, that is the government agencies responsible for the multisectorial, for the coordination of the multisectorial response to gender-based violence. We all work together to launch this protocol. So once the protocol is in place, it's possible to offer the service also in governmental hospital and also in urban areas within the framework of the protocol. So it was a very important milestone for us. It was launched in 2017 to really start the service provision in urban areas. This happened at the same time when it was launched the national SOPs for the prevention response to family violence and GBV. It was a government-led initiative. There was assigning role and responsibilities to all ministries and governmental and NGOs in the response to gender-based violence. So once the protocol was out there, the SOPs were out there, for us was also very important to start prioritizing what we need to do in urban areas. And for us was filling the gap in the provision of 24/7 CMR services, because the health facility that UNFPA supports with our partner, they only provide services, they are primary healthcare centers, so only 5 days a week from 8 to 5. So we were basically not covered during the weekend in the evening. So to do so, next slide please. We really built on the lessons that we learned in establishing the services in the camp. And there was a need really to stop providing only trainings each year, because service providers move and change. It's very important to have a more sustainable capacity building approach. So we work with MOH to develop a capacity building strategy and create a national team of master trainers. So we did a TOT, training of trainers. We started with 24 people, actually only 1/3 of them passed the training, because we were looking not only at medical skills, but also at attitudes regarding GBV, so, and the training skills. So only 1/3 of them passed the training. But for us, it was important to have a very strong national team of master trainers that then replicated at cascade the training in the 3 referral hospitals in the center, north and south of the country, reaching over 50 other doctors. Those national team of trainers is also part, we created a community of practice, so we keep always them engaged when it comes on CMR, exchanging knowledge, exchanging questions. They also received a coaching program for 1 year and a refresh training. The provision of CMR services is not something you do on a daily basis. You will need always a refresh. You will always questions coming up. So it's very important to create a community of practice where you can ask questions to other peers and learn from each other. And one unintended effect that we had was actually the doctors that we trained were working with us from the Ministry of Health on the CMR. They start becoming very strong advocates against mandatory reporting. So mandatory reporting, according to the law in Jordan, basically the health provider should report to the police before providing any service for sexual violence survivor. This was a big obstacle for survivors to seek help. Some of them would like to have medical attention, but not calling the police because of their status, because of their situation. But according to the law, this is not possible. The health providers need to call the police before providing any service. The doctors, once receive the training, they start becoming very strong advocates to revise the law. And so this was a very important, now they are very important allies for us. UNFPA has continued to provide supporting MOH in providing commodities. We are actually shifting from the kits to providing procurement in bulk, because the market in Jordan can absorb actually local procurement. And as for us was important that the model and the quality of CMR services provision in the camp was instrumental to really transfer the practices to the national institution. So I have last slide with few conclusions. The humanitarian response, we started in the camp and introduced a very higher standard of care. And now this is a government-endorsed nationwide response. For us, this was a very good example of how in practice the nexus between humanitarian and development work, but also was an example of the role that UN agencies can have in facilitating this connected transfer. So that's all from my side. Thank you. There is the last slide, yeah, with my thanks and my contacts.
Thank you so much, Pamela, for sharing the fascinating account of how you developed a sustainable system in a challenging setting. And again, many lessons learned, I'm sure, for other countries. So thank you again. And now we will move to the third presentation. And I'd like to introduce again Zara, who is with us presenting from Kabul. Thank you, Zara, over to you. The establishment of the Afghan Midwives and Nurses Council, another milestone in building a resilient health system. Thank you, Zara.
Thank you, Sheena. Hello, everyone. My name is Zahra Mirzai. I am president of Afghan Midwife Association and Midwifery and Nursing Team Leader, Jipaigo, Afghanistan Country Office. Today, I am here to present you how the midwives and nurses in Afghanistan success to establish a regulatory body to bring changes in quality of maternity care and strengthen the health system. Next slide, please. As the data shows, although the modest improvement in addressing still maternal and child mortality rate is very high. Afghanistan is a country with lots of geographical difficulty. 3.5 decades of conflict cause a fragile health system, poor security situation, and lots of cultural and gender-related barriers against women empowerment. Civilians are killing in every week and every month due to suicide attack, which includes women and children. And another big concern for us is targeted attack to health facility. Midwife Mariam was mother of 3 children, and she was provided services to women for 8 years in the most remote and insecure area of Afghanistan. She was killed in an attack in Dasht-e-Barchi MSF hospital in May 2020. Next slide, please. Why investment in midwife? Evidence shows midwives are essential to the provision of quality of care in all settings globally. But in Afghanistan, midwives are essential healthcare provider. Everyday hero who serve community in very remote, hard to reach and insecure area where either male or female, other female health care provider are not available. So educated and regulated midwives have an essential role to play in preparing and providing sexual reproductive services due to their unique knowledge and skills and their position as frontline provider and geographic and social proximity to the community they serve. Evidence support investing in midwives to build a more resilient workforce as part of comprehensive system strengthening. Midwifery profession have 3 pillars, which is education, association, and regulation. Luckily, we have a comprehensive education system in place in Afghanistan since 2005. Afghan Midwifery Association also established in 2005 and has lots of achievements as biggest professional association in Afghanistan. But the missing pillar was regulation. Then AMA worked on establishing the regulatory component for a strong profession, which began in 2009. Next slide, please. Afghanistan is challenged with ending preventable maternal and child deaths, despite concentrated effort to increase number of midwives, increase access to reproductive health services, as well as all efforts toward improved quality of care. Still shortage and misdistribution of midwives, gender-related barrier, as 100% of midwives in Afghanistan are female. poor working environment, especially for midwives and female nurses, and worsening insecurity are challenges we are facing with them. Establishment of AMNC was an steps to increase quality of care and patient safety. Next slide, please. Considering Afghanistan's worse security situation, fragile health system, it was an urgent need to regulate and standardize large part of services provided by midwives and nurses to the most vulnerable part of community, which are mothers and children. On the other hand, private midwifery and nursing institutes every year train and graduate midwives and nurses, but there was not any regulation system to make sure about their accreditation, quality of education system, and make sure the graduated midwives or nurses meet the International Confederation of Midwives and International Council of Nurses competency, and they are fit to practice as midwives and nurses. Besides that, public expectations are increasing for acceptable healthcare and competent, safe, and accountable healthcare providers, providing the highest level of quality healthcare to people of Afghanistan by ensuring an educated, competent, and regulated midwifery and nursing workforce can be achieved only by having a functional midwifery and nursing council. Regulation is a mechanism to raise the status of midwives and nurses and to ensure that they have authority to act on their own professional judgment within their scope of practice. Next slide, please. MSF or Midwifery Services Framework, which is a new tool introduced by International Confederation of Midwives to guide countries through the process of strengthening and developing their midwifery services. Afghanistan started MSF implementation in early 2016, and it really helped us to speed up the process of AMNC establishment and recognize it as an urgent need and short-term priority. But overall, establishing council took almost 9 years, continue advocacy and activity. Next slide, please. The facilitator factor for establishing AMNC was included to many factors like advocacy and resource mobilization by committed and passionate leadership initially from Midwifery Association and then with the White Ribbon Alliance in Afghanistan 2015. Midwives welcome and valued regulation as an opportunity to strengthen the profession. Although the Nurses Association participation was more limited, but expatriate nurses, mainly from Aga Khan University, technically supported the process of AMNC establishment. The establishment of AMNC was a result of a strong collaboration, commitment, and effort of many partners working with Afghanistan Midwifery and Nursing Association, most of whom have been supporting the MOPH in establishing and strengthening the midwifery and nursing since 2009. And we had also support of some politicians like Parliament member and First Lady Office and some international supporters like JPIGO, GIZ, Swedish Committee for Afghanistan, and Aga Khan University. Next slide, please. The timeline of 9 years is a notable and various barriers were faced. Advocacy for establishment of AMNC started in 2009, all together with advocacy for establishment of Afghan Medical Council. But in more than one event, it was suggested that Midwifery and Nursing Council be placed under umbrella of Medical Council, but it was resisted and considered to reflect a paternalism, a lack of trust on midwives and nurses to assume leadership position, and a lack of clarity of autonomous health profession regulation. Regulation continue to be a challenge in many countries. Next slide, please. I think midwives and nurses in Afghanistan have demonstrated an incredible resilience and commitment in realizing their vision of establishing a council, but it is just a start of a challenging journey for us. We need ongoing support for our network inside and outside the country to maintain and strengthen the resilience within our profession to enable significant contribution to make improving outcome in Afghanistan. Next slide, please. In this year of nurses and midwives, the essential contribution that nurses and midwives make every day in every country is recognized. Establishment of emergencies started a dynamic journey toward improving the quality of care through the regulation and strengthening midwifery and nursing profession. At the end of my presentation, I would like to say we really appreciate the collaboration and leadership of Ministry of Public Health in progressing the establishment of Afghan Midwifery and Nursing Council, as well as many partners over the years who contributed time, technical and funding support. And also I would like to thank all midwives and nurses inside and outside Afghanistan for their technical support and the time they spent for establishment of AMNC and writing this commentary. Thank you very much for your attention.
So thank you so much, Sarah, again, for sharing what was quite a long journey that many of us participated in, but we had a good result at the end of the day. So thank you for the good presentation. So now we have about 15 minutes for questions and answers to our panelists. This will be supported by my colleagues Blami and Stacey, who will, I hope, let me just check in if we have some questions. I'm just going to, do we have any questions, Stacey and Blami, from our participants?
No, so far no question.
No questions. Does anyone have any questions they would like to pop in the box at the bottom of the page? Any questions for the panelists? If not, I can.
It seems that everything was very clear. Very informative. Okay.
I have a question, maybe to kickstart this process, if I could ask Pamela. This may be, anyway, I'll ask you the question. Pamela, I think,
excuse me.
Yeah,
there
go
are
ahead.
2 questions now.
Oh, there are 4 questions now. Okay, please, go ahead.
Unfortunately, the question was not directed to one of the panelists. Okay, the first question, yes. How the COVID pandemic is being addressed in the panelists' respective countries?
Oh.
Okay, who want to take the first step?
That's a big question.
I can start.
Okay, please go ahead.
I can start. Thank you for the question. It's a very timely one. In terms of clinical management of rape services, when the COVID-19 lockdown started in Jordan, the government decided to close everything and we all went in quarantine and the lockdown. It included also closing the primary healthcare centers that were providing clinical management of rape. So they were initially closed, and the referral hospitals that have clinical management of rape are actually the COVID-19 hospitals for referral. So it was not safe to send survivors there because they were also where the COVID-19 cases would go, government hospital. And the primary health care center were initially closed. Then we did a lot of advocacy with the government and eventually they reopened. So in the first 2 weeks, what we came up with for clinical management of rape is that we had, through our hotlines, basically the doctor was on call, and the doctor could move and basically get to the clinic and get the kit and provide the services. So we created for a couple of weeks on call service for emergency cases of rape. Then eventually primary healthcare services reopened, and so was possible to walk in.
Okay. The second question is related to how do you engage with state actors in the refugee camp?
So this is for you, Pamela. Is that right?
Pamela, I think for you, yes.
How we engage with the state actors in the refugee camps?
Yes, in the refugee camp. What were some of the key challenges in doing that?
Yeah, I mean, the key challenges were, let's say actually in the camp was relatively easier than in the urban areas. But of course, we had to basically speak with the camp coordinator as well as with the SRD, that is basically the part of the police that is responsible for the management of the camp. So it's the camp management to make sure that they would understand how the services were provided within the clinics. So I think it has been actually easier in the camps than outside. And the main challenge was just to make sure that the camp managers and the representative of the government in the camp were well aware of the service provider and also well aware of the quality protocol. Because this is something else we always need to deal with the authorities. They say they want to know. They want to know names. They want to know names of survivors, names of the perpetrator, because of their security perspective. But also we have a confidentiality protocol. So it is something that we always need every time there is a change in the camp management. We need always to go through, re-explain the confidentiality protocol we are abide to.
Okay, thank you, Pamela. Now for Zahra, what was the role of professional association in the council?
Actually, the professional association was the person start this advocacy. As I mentioned, it was a 9 years advocacy effort, but it started with a suggestion come by our association. Then we have to be in coordination with all other partner. Then we start our advocacy within our partner and our Ministry of Public Health, and we success to have the other partner support like the international organization and national organization. All of them work for midwifery and nursing in Afghanistan, and we success to convince them that yes, establishing a regulatory body is a good suggestion, and it will affect improvement of health outcome, maternal and child health outcome in Afghanistan. Then we success to have a harmonized advocacy with all other national and international partners.
Okay, second question for Zahra. Is continuous professional development linked with the regulation process?
Yes, of course.
Okay.
Yes, yes, of course.
Okay. For Erickson, is MIS provided in isolation center during the COVID time?
Okay. Prior to this pandemic, the Philippines had one of a major disaster, which is an eruption of one of our volcanoes in southern part of Luzon. At that time, one of the Centers for Health Development of the Philippine Department of Health is just in the process of streamlining MISP into its programming. They were about to have it vetted by stakeholders and partners, but unfortunately, we were not able to do so because of this crisis. So basically, and as I've mentioned in my presentation, MISP is still a new initiative here in the Philippines. So we are yet to see how it's being implemented. several times in the past, people are saying that it's reproductive health in crisis, it's RH and emergencies and whatnot. So we are yet to see how the whole package of MISP, from planning up until coordination, would be implemented. So we are very much looking forward on MISP being implemented at a larger scale nationally.
Okay, thank you, Erickson. For Zara, were you able to advocate publicly?
Yes, at the beginning of our advocacy, we conducted many consensus building workshop, and we invite our partner, and the community we advocate for them was midwives and nurses in Afghanistan. And then we conducted like a survey to have enough data and information what they really want, and the effect of having a regulation body in improvement of their job and profession. And the result of this data help us to speed up the process of establishment.
Thank you. For Pamela, how do you ensure that all those living in the urban areas report to the authorities in any way they have experienced DBV?
Yeah. Thank you for the question. We actually propose a survivor-centered approach. So we make sure that survivors reach out for services, not necessarily report to authorities. So if the survivor doesn't want to report to authority and only receive healthcare and psychosocial support, this is actually fine. And then she has the power to decide if she wants to involve the police or not. In Jordan, we engage in very massive campaign to spread the numbers of hotlines that are available, or what we call case management agencies that can provide psychosocial support and really walk through the survivors of all the options, calling the police, seeing a doctor, talk with a lawyer. So what we are really promoting is making sure the survivors know the hotline to call when they need help. And then based on the case, they can decide if they want to report to the police or not.
Okay. Back to you, Sheena.
Thank you, everyone. So we've completed the questions?
Most of them. Some are comment, yes.
Okay. So if there's no more questions.
That is a question. What is the biggest challenges ahead frontline workers in any of these countries during the pandemic in terms of enforcement of policy to provide safe care for women? Challenges for frontline health workers during the COVID pandemic in terms of enforcing policy to provide safe care for women. Any of the panelists can answer. Let's go to Erickson. Erickson, are you there?
Yeah. So for the Philippines, the Philippine Congress passed a law wherein frontline health workers who would be affected by severely affected by COVID would be provided with 100,000 pesos, and those who would succumb to COVID-related deaths would be provided with 1 million pesos. But it's so unfortunate that nurses, doctors, and midwives and other health workers have to face the reality that because what this pandemic has showed us is that how fragmented and how it did not only disrupted an already disrupted health system, but it just showed us how unready we are in terms of this. We have hospitals now closing down because of they're saying that they have full capacities. They have, but the government is saying that we have this number of hospital beds, we have this number of ventilators and ICU beds and whatnot. But the reality is that health workers are no longer in the hospitals. Health workers are also affected by this pandemic.
Thank you, Erickson. Back to you, Sheena.
So thank you. I think that question, we could discuss that all day. I think what has come out of the pandemic and the global response is how many health systems are being stretched, including in high-income countries, and how the importance of being ready for these shocks to the system, whether it's a pandemic, a conflict, or a humanitarian disaster. There is increased need across all countries to improve the readiness in terms of preparing the workforce and making sure that essential and emergency services can be provided. So I think this has really shaken up a lot of countries, including the UK, where I am now, as well as other very fragile countries like Afghanistan, which has been very badly affected by COVID. So if there's no other questions, I think we can wrap up this first webinar. And I would very much like to thank our panelists this morning, Erickson from the Philippines, Pamela from Jordan, and Zara from Afghanistan, as well as my colleagues, Stacey and Blami, and our IT support, Diane in Jakarta, for their support during this webinar. And for some reason, my screen has frozen again, whatever that's about, I don't know, but let me pull up this one and just remind everyone that there is an ongoing series. IWAG are streaming various webinars over the next few weeks. Please check out the IWAG site for when these will be conducted. There will be further webinars on the topic of SRH in the humanitarian development nexus. So in the meantime, thanks to everyone for joining us. Stay well and stay safe. Thank you again, everyone.
Okay, bye-bye.
Bye, everyone.
Have a nice day.
Goodbye. Thank you.
Thank you. Shukran. Tashakkur. Bye.
Bye.